When you think of adrenaline, you probably think of a huge full body rush, right? Like you see on TV, or maybe even something you felt yourself.
Yeah, systemic jolt.
Exactly. But today, we're diving into the complete opposite. We're talking about using that same powerful drug, epinephrine, in this incredibly precise, incredibly localized way to stop a life-threatening bleed deep inside the GI tract.
And our guide for this, it's actually some really incredible source material. It comes from a series of instructional videos from Dr. Gautamukala S. Raju's YouTube channel, which really details these fine-tuned techniques.
So our mission here is to go way beyond just, stop the bleeding.
Yeah.
We want to get into the details, the prep, the razor-thin margin for error, and why every single step is so critical for the patient.
And I think the first thing to get your head around is the role of the drug here. In, say, an allergic reaction, epinephrine is like a systemic fire hose. But in endoscopy, it's more like a surgical laser.
A laser, how so?
Well, the goal is to cause this intense, localized vasospasm. Basically, you're telling the tiny blood vessels right at the bleeding site to clamp down hard. It's like a chemical bandage that works almost instantly.
And that speed gives the doctors the time they need.
It's all about buying time.
Okay, so let's start there. In what kind of situations, what scenarios does a doctor reach for this tool? When is this injection the first line of defense?
It's really for those moments of brisk, active hemorrhage. I mean, when the blood flow is so heavy that the endoscopist literally can't see the source of the bleed to fix it properly.
Just too much going on.
Exactly. And the sources point to two big ones. First is severe peptic ulcer bleeding, which can be really profuse. And the second is diverticular bleeding, where a vessel just ruptures.
So in both of those cases, the epinephrine's kind of like slowing down a river so you can build a dam.
That's a perfect analogy. You inject it right near the vessel, and that clamping action just slows the torrent to a trickle, and suddenly you can see again.
Okay, that covers the big emergencies. But you mentioned another use, one that's less of a crisis and more proactive. That one surprised me.
Right, and this shows the subtlety of the tool. It's used in polypectomies, that's removing polyps. For really large polyps, especially ones with a thick stalk, there's a high risk of bleeding when you cut them off.
So they inject it before they cut.
Exactly, right into the stalk.
And what's the thinking there? Is it just to stop potential bleeding?
It's actually two things. First, yes, the vasospasm makes the cut itself much safer, much less bloody. But second, the fluid you inject actually creates a little pillow, a little cushion of tissue.
Oh, I see.
It lifts the polyp up away from the deeper muscle wall. That gives the doctor more room to work and helps prevent them from accidentally cutting too deep.
So it's both a chemical and a mechanical safety net.
But, and this is a really critical point from the sources, it doesn't solve the long-term risks.
What do you mean?
Using it for a polypectomy makes the cut safer in that moment. But epinephrine is a temporary drug. It does not, and I'll repeat, it does not prevent delayed bleeding that might happen a day or two later.
So once the drug wears off, the risk is still there.
The risk is still there.
That brings us right to the technique itself. With such a powerful drug, you can't just be casual about it. What does the preparation look like?
It's a non-negotiable protocol. And it all starts with the dilution. The concentration is everything. For most of these active bleeds, the standard is a 1 in 10,000 dilution.
1 in 10,000. So 1 part epinephrine to 10,000 parts saline.
Correct.
Why so specific? If it's an emergency, wouldn't you want it to be, stronger?
That's the trade-off. A stronger dose would cause a more intense clamp down locally, sure, but it massively increases the risk of it being absorbed into the body and causing dangerous side effects, like a cardiac arrhythmia.
I see.
So 1.10,000 is kind of the Goldilocks zone. It's strong enough to work locally, but dilute enough to minimize that systemic risk.
Okay, that makes sense. So before the catheter even goes into the endoscope, what's on the safety checklist?
It's all designed to prevent human error. First, labeling. Every syringe, every container has to be marked with the concentration, the date, the time, and the initials of the person who prepared it. No exceptions.
Right.
Second, you check the catheter itself, make sure the needle slides in and out smoothly. And third, and this is vital, is the bubble check.
The bubble check?
You have to make sure the syringe has absolutely 0 air bubbles in it. None.
Wait, why is that so critical? You're injecting it into tissue, not directly into a vein, right? What's the harm of a tiny bubble?
Well, that tiny bubble could be a catastrophe. If you accidentally inject that bubble into a blood vessel, which is easy to do in a bleeding area, You risk causing a systemic air embolism.
Oh, wow.
Yeah, an air pocket that can travel to the heart or the brain and block blood flow. It's a low probability event, but the consequence is so high that being meticulous about it is part of the core safety protocol.
That really changes how you think about just a simple check. So what about the handover, when the assistant passes the catheter to the endoscopist?
Two key things. First, you prime the catheter so the epinephrine is right at the tip, ready to go. But second, when you hand it over, the needle must be retracted, pulled back inside its sheath.
To prevent an accidental needle stick.
Exactly. Protects the endoscopist. And then comes the communication during the actual injection.
You mean the counting?
The counting. The team has to count the volume out loud. 1 cc, 2 cc's, 3 cc's. It sounds simple, but it tells the endoscopist how much fluid they've delivered, and it lets the whole team track the total dose to prevent giving too much.
So we've established it's fast, it's effective, it clears the field. But here's the big question, the clinical trap. The bleeding stops. Is the job done?
Absolutely not. And this might be the most important takeaway from the sources. Epinephrine is a temporary fix. That's it. It's a chemical tourniquet.
It just presses pause.
It presses pause, it forces the vessel shut, but it doesn't repair the hole.
So once the body metabolizes that epinephrine, what happens?
The vasospasm wears off, the vessel relaxes, and because it's still damaged, the patient is at an extremely high risk of rebleeding, maybe even worse than before. If all you do is inject epinephrine, the job is dangerously incomplete.
So you have to follow it up immediately,
Immediately, you have to apply what's called definitive hemostasis.
which would be what? What are the options?
The most common are either a mechanical clip, it's like a tiny staple that clamps the vessel shut for good, or a thermal device that uses heat to cauterize and seal the vessel. The epinephrine clears the way so you can put on the permanent patch.
Let's shift from the local site to the whole patient. We're injecting adrenaline, even if it is diluted. What are the systemic risks the team is watching for?
Even with careful injection, some of it gets absorbed into the bloodstream, and the biggest danger there is to the heart, especially in older patients who might already have heart conditions.
What could happen?
They can develop serious cardiac arrhythmias, irregular heartbeats, or sudden sharp spikes in blood pressure, a hypertension.
Both of which are major problems. So what kind of monitoring is going on?
It has to be constant. The moment that first CC goes in, the team is watching the EKG for the heart's rhythm, they're watching the heart rate, and they're watching the blood pressure, all continuously.
And what if there's an anesthesiologist in the room?
Then it becomes a team sport. It is absolutely mandatory that you tell them, we are injecting epinephrine now. You have to say it out loud.
Why is that so important?
Because it gives them a heads up. They can watch their monitors even more closely and be ready with medications to counteract any dangerous heart rhythm that might pop up. It's all about coordinated safety.
So this whole deep dive really paints a picture of this delicate dance of precision and timing. We learned that the standard is that 1 in 10,000 concentration.
Right, that perfect balance.
We saw the critical safety checks from the labeling to getting rid of every single air bubble to that loud counting during the injection.
But the real takeaway, I think, is the strategy. Epinephrine is the crisis tool. It's not the solution. That temporary chemical stopgap has to be followed by a permanent fix, like a clip or thermal therapy.
So what does this highly detailed two-step process mean for you listening at home?
Well, the sources really underscore this idea of knowing the difference between slowing a crisis and actually resolving it. Epinephrine buys you time, but that clock is ticking fast. And it raises a bigger question, I think. In any high-stakes problem, whether it's medicine or finance or anything else, how often do we rely on a quick fix to feel better without having a real structural solution ready to go right after?
So when you face an emergency, do you have a two-step plan? A stopgap and then the definitive fix?
That's the real challenge, isn't it?
Something to think about. Thanks for diving deep with us.